So nutritional will be the most common ones. And what are the pointers that if you have somebody who comes to you with the rickets for the first time, has a possibility of a non-nutritional or a refractory rickets?
Having fractures associated with rickets like condition, or someone who has a failure to thrive, then these are the conditions.
So significant failure to thrive, features of RTA like polyuria, atherosclerotic breathing. If you have a pathological fracture, you have to get worried about in that scenario. Now, what are the common causes of non-nutritional rickets / refractory rickets, Vibha?
Rickets. Another would be the RTA.
So renal tubular acidosis, hypophosphatemic rickets. And the most common would be renal failure. So that is something, of course, you will do it in the initial phase. So we'll try to go forward on that. So rickets seems to be a reasonably simple condition to evaluate, but often we have got confusions which go off. So we had this 3-year-old boy who was referred to us in which of quote unquote a diagnosis of refractory rickets, had been given vitamin D 60,000 international units and complained of bone pain and a high alkaline phosphatase. And based upon these findings, the clinical team thought that this could be a possibility of a refractory rickets. But as we will discuss subsequently, that we do have some physiological responses to vitamin D, which include an increase in bone pain and an increase in alkaline phosphatase, which do not indicate a refractory rickets. And what we need to look at is the line of healing which was present in this case. So while this case was unnecessarily being advised, a lot of investigation in the form of a blood gas, calcitriol level and PTH, they were not required. So what we need to understand is that there are certain scenarios in which you will respond in a way and you don't need to work up extensively from that regard. So this is a normal response for rickets. On the contrary, we have this 14-year-old boy who presented to us with lower limb abnormalities predominantly and had been given huge amounts of vitamin D, and there was no line of healing. He was again referred as quote unquote nutritional rickets. So in the first case, we were making physiology into pathology. Here, a pathology was turned out to be in a physiological cause, and this unfortunately resulted in the development of nephrocalcinosis. If you have a late onset rickets with predominant lower limb abnormalities with a normal PTH, normal calcium, think of hypophosphatemic rickets. So when we talk about rickets, we have to balance between the not doing too much workup where it is not required, while not missing on pathological cases. So this missing and messing is something which we want to avoid. Rickets overall is a reasonably common condition, usually nutritional, but refractory rickets may pose challenge, as we saw in the second case in that perspective. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of information about pediatric endocrinology, including resources and courses. Our e-learning portal on YouTube, which has got a lot of videos on pediatric endocrinology. Our validated courses, which provide information, including fellowship course and postgraduate courses as well. And our regular programs in the form of grand rounds, journal clubs, and PG lecture series as well. We've got publications across board from protocols to advanced in basic pediatric endocrinology and mobile applications which guide assessment.
Here we start off with something simple. What is the earliest manifestation of vitamin D deficiency in infants?
So you can put your response. Next Q&A. So Dr. Palani Raman is saying head sweating as an important manifestation which is there. Anybody else has any answers? So we are asking mainly in terms of skeletal manifestation, I believe. So growth deficiency, tetany, so what are you talking about?
Yeah,
craniotabes. So skeletal manifestation, this will be something which you can pick up very quickly. But other manifestations, as people have talked about, are growth failure, head sweating, and other parameters may also be there.
And if people could answer, what other conditions may have this sign, especially for the general pediatricians or people giving entrance exams? You mean
so one or the other causes of craniotabes other than rickets?
Yeah.
We are looking for answers. Not yet. What is your answer?
Okay, so congenital rubella and osteogenesis imperfecta may have craniotabes early. Also, what radiological sign or what radiological imaging would you advise in an infant with rickets?
So for infant with rickets, what specific parameter you will ask for? We'll look for the answers on that. X-ray of the left hand.
Yeah.
So left hand, the wrist is the most common. Dr. Parani Raman from Pondicherry has correctly answered that. It's very important. You can also look at the chest X-ray. And chest X-ray is important because especially if you're looking at a very young child in which you want to look for hypophosphatasia, you may find ribs which are very, very small and you may have fractures. So even otherwise, hand is a very good X-ray to go forward.
And as
So Dr. Gurbinder, Dr. Bharani, Dr. Musa Kutti, all of them are saying X-ray, so this is very precise. They carry on.
as the child gets older and starts bearing weight on the lower limbs, you will see changes in the knees, but initially you may not see changes there. We have a 1.5-1.5 month old, apparently well infant who presented with generalized tonic seizures. We ruled out sepsis and hypoglycemia here. And the next thing that we see is that calcium was 5.2, phosphorus was 8.3.
So hypocalcemia with hyperphosphatemia in an infant with the seizures. Yeah.
Seizure, yes. So we saw that the calcium was low, phosphorus was high. We went ahead with PTH levels and we saw that it was elevated. So what is the diagnosis here? And is there anything else you would like to work up before?
So, hypocalcemia, hyperphosphatemia, PTH, do they have any rickets also?
No other features.
No other features of rickets. So
Well thriving.
Hyperphosphatemia, what are we looking at? PTH is also high. So is it pseudo-hypoparathyroidism? So we are looking for answers. Dr. Parani Raman is saying pseudo-hypoparathyroidism.
Yeah.
Dr. Bharani is talking about neonatal hypoparathyroidism. So you have to, of course, look at it is basically a scenario of hypocalcemia with hyperphosphatemia and a high PTH. In a normal universe, you will say most likely pseudo-hypoparathyroidism.
Yes.
But we know that there is a significant chance of vitamin D deficiency causing PTH resistance. So it's actually a deficiency of vitamin D which is causing this resistance. Dr. Gurbinder Sekho has correctly mentioned vitamin D deficiency. So what are the mechanism of vitamin deficiency causing this high phosphorus?
So the vitamin D deficiency causing high phosphorus.
So why is this not associated with hypophosphatemia?
PTH resistance.
Secondary
Resistance. Yes.
Next.
Again, we have a 3-month-old, apparently well infant with generalized tonic seizures. We've ruled out sepsis and hypoglycemia. We find that the calcium is 5.6. Here now the phosphorus is 2.1. We did not want to make the same mistake again. We went ahead with the vitamin D levels, which was in the normal range. PTH again in this setting is now high.
So you have high PTH, normal vitamin D, hypocalcemia and hypophosphatemia. So what are you looking at here? It's different from the last case. Vitamin D is normal. You would definitely like to look at whether there are rickets on the X-ray of the chest or on the hand. Is it there?
Clinically, there was no rickets. Only seizure was the manifestation.
Okay, so any considerations here? So this is clearly a case which is not vitamin deficiency. This is not pseudo-hypoparathyroidism or hypoparathyroidism. This is a vitamin D related cause. So we are looking at VDDR as a possibility. So VDDR2 or 1, whatever we have not done the calcium level you have done, it's high.
Yeah.
So this is VDDR2.
14-month-old boy who presented with rickets. Now we saw that the weight was normal, but there was stunting. We saw that the calcium was low, the phosphorus was normal, ALP was elevated, and we did the vitamin D levels, which came out to be low. We got the nutritional history and found out that the child was exclusively breastfed, did not receive supplements, and we established that this was a nutritional rickets. Now I wanted to know what treatment would you prescribe to this child?
So we have a 1-year-old child who has nutritional deficiency. What sort of treatment in terms of calcium dose, in terms of vitamin D dose and formulation you will use? So, while we are waiting for the answers, do you think you would think of a refractory rickets also as a possibility in this case, or you are fine?
Not upfront, knowing that history was classically suggestive of a deficiency.
So you have got
There's no
mild
significant-
failure to thrive, which is not very excessive.
Hmm.
Vitamin D levels are very low, so I would not be too concerned about that. So Dr. Bharani is talking about 60,000 fortnightly. Dr. Musa Kutti also the same. Dr. Palani Raman, calcium, vitamin D and protein calorie supplements. I think we have to do that. What is your take on this?
Okay, so I wanted to raise another question. At calcium of 5.2, would you like to do something else differently, at least in the initial part?
This is a very important scenario that if you have hypocalcemia, if you give them vitamin D, it is going to take a long time for this vitamin D to get corrected and this calcium level to normalize. So in this scenario, you need to probably give a more rapid acting preparation like calcitriol in the initial phase for 3 to 5 days, as we just did in the other case, and you will build up the calcium levels and then go forward from there. I think this is an important pointer that if you have severe hypocalcemia with rickets, correct with calcitriol also in the initial phase.
9-month-old girl with craniotape.
What happened?
I just want.
Cranial
Okay,
rickets,
yeah, 9-month-old girl with craniotapes in widened wrist and birth weight. She was a term 3 kg baby. As you can see on the X-ray, there are classical features of rickets. Now this child, there was a history that she was growing well almost until 6 months of age, and beyond 6 months, the mother has noticed weight loss, and as you can see, for a 9-month-old, her weight and length both are compromised. There's classical history of passing pale colored stool, recent onset, bleeding manifestations, and distension of abdomen. So, what are you considering here? I mean, what diagnosis would you consider here, and how would you
She
like to
has
manage?
rickets which has not responded to vitamin D, or you don't have a history?
We don't have a history yet, but she's a 9-month-old baby who has presented with features of rickets and has failure to thrive with.
So Dr. Bharani is mentioning celiac as a possibility. Would you consider that?
I'm not in a 9-month-old. No, yes.
The gluten exposure will be less. So yes,
Yes.
we're talking about some malabsorption.
Yes.
But what form we're looking at the liver disease
Yes.
as a possibility. So cholesterol, Dr. Dhruv, Dr. Palani, Dr. Musa Kutti, Dr. Sushma Kaur is mentioning malabsorption. Yes.
Yeah.
So a form of hepatic malabsorption we're looking at. And as we discussed, that liver disease does not cause rickets
Yeah.
unless it's very advanced, or you have significant malabsorption,
Yeah.
or you have tyrosinemia, cystinosis, or other things. So
So-
what did we do further?
So this was basically on workup found out to be biliary atresia. And what other micronutrient deficiencies would you expect to simultaneously coexist in such children?
So there will be a lot of fat soluble
Right.
nutrient deficiencies which you have to be worried about.
This 2.5-year-old boy presented to an orthopedic surgeon with knock knees and gait abnormality, basically. And again, we can see in the X-ray of the knee that there is some metaphyseal cupping, splaying, fraying. The weight and length were not quite compromised. So this child had received vitamin D intramuscular 6 lakh units, and even at 12 weeks, we saw that there was no line of healing. Now, this child definitely qualifies as a refractory rickets. On workup, we found that the calcium was 8.1, phosphorus 2.1, vitamin D was 200, and PTH was 70.
So low level of phosphorus and calcium, vitamin D is high, PTH is mildly elevated. So what are we looking at as a possibility? Maybe we want to have the answers. Hypophosphatemic rickets, do you agree? PTH being high
And not so young.
by
Probably.
VDDR type 2. So you can't say the moment, yes, so we are dealing
What
with
advice?
Bharani with VDDR. So it's mostly VDDR 1 or 2, so calcitriol levels will be done. So I think that algorithm will give us a clue in this regard. Yeah.
Now we have a 5-year-old boy who presented with bowing of legs. The weight was significantly compromised, height slightly. He had severe pallor and history of frequent diarrhea and pica. And this is what we see on examination.
So there is definitely a lot of clubbing. So you've given the diagnosis, but already Dr. Palani and Dr. Bharani have mentioned celiac as a possibility. So if you have rickets with anemia, with clubbing, think of celiac as a possibility. Dr. Dhruv has also mentioned celiac. Yeah, please go ahead.
we had this 3-year-old girl with resistant rickets. She presented an history of polyuria. Height and weight were significantly compromised. The blood gas showed a pH of 7.18 with bicarb of 11.7 and a urinary pH of 5.6.
So you have acidosis with a urinary pH which is alkaline.
Yes.
Acidic blood, alkaline urine, problem in acidification. So the diagnosis is RTA2, Dr. Dhruv, Dr. Bharani, both of them talk about that.
But is there something else you would like to rule out here before you label this child as an RTA?
Yeah. So again, creatinine will become important as we saw in that case. So before you diagnose it, Dr. Dhruv will mention again creatinine. So you have to look at creatinine before you label it RTA.
And this child has a very classical frontal bossing and rachitic rosary, if I may this point.
The CKD becomes important.
Now, we had an 11-year-old boy admitted with vomiting, dehydration, and failure to thrive, who had height of 124 centimeters, weight of 20 kgs. Both were significantly compromised. As you can already see in the X-rays, there are rachitic changes on the wrist as well as knee joints. Sodium was normal, potassium was 2.1. He had a pH of 7.25 with an anion gap of 12. Metabolic acidosis with normal anion gap. Now, metabolic acidosis with a normal anion gap. Further workup in view of rickets showed that calcium was 8.6 and phosphorus 1.9 with a very high ALP level. So,
and you have a normal creatinine. So what are we looking at in this child who has got acidosis, who has got hypophosphatemia, high ALP and a normal creatinine? Proximal RTA, Dr. Musa Kutti, Dr. Bharani is saying RTA. What are you thinking of? So it's more like a RTA, and then you classify further. The reason why you probably this RTA was a bit less because the ALP was very high, but you can have variation as well. So again, this is considered RTA.
Now, this was a very interesting case. She was a 3-year-old girl who had initially presented with failure to thrive in polyuria. She underwent a battery of investigations, was advised treatment, but they were not compliant to the treatment. She presented again at 9 years of age with persistence of polyuria. Now, in view of persistence of polyuria, the attending pediatrician had done a urine routine, which had shown glycosuria. So they went ahead with glucose blood sugar profile, and they saw that the blood sugar fasting and postprandial were normal. The HbA1c was in the normal range, and with this presentation, she was referred to an endocrinologist saying that the urine glucosuria does not match with the current investigation. When she was seen by us, she had features of rickets, and we went ahead with further workup, which showed sodium of 140, potassium was borderline low. Creatinine at 9 years of 0.8 was not significantly elevated. She had calcium of 8.1, phosphorus of 1.9, metabolic acidosis with pH of 7.2 and normal anion gap.
So there is a mildish metabolic acidosis with a low phosphorus. And I think everybody has got the diagnosis. Dr. Musa Kutti, Dr. Palani Raman, Dr. Bharani, and Pankani. I think this is a classical picture. So again, look at urine routine and look for glucose. And you've said a specific thing, photophobia.
Yes.
What are we looking at here?
So this was what we saw on the slit lamp examination, and it showed cystine crystal.
So Dr. Bharani has mentioned cystinosis. Yes. So I think many of our messages have really gone through probably there.
And if I may just ask, what is the treatment of choice in children with the drug of choice and the treatment of choice? If I may.
So what are the treatment anybody would like to add? They're waiting for response. This is out of course question.
Okay. Systamine therapy is used, systemic as well as oral eye drops, both
they will now
is available. And the ultimate will probably need kidney transplant.
You to have a look at our website, at our various courses, our publications, our learning portal, as well as the mobile application.